Welcome to today's Research America Alliance member web meeting. Thanks to everyone in the audience for joining us, and as always, thanks for your partnership. We have two guest speakers with us today. I'm so excited to tell you that first we have Dr. Carolyn Clancy, who is the Acting Deputy Secretary for Veterans Affairs. Dr. Clancy will speak to us about VA's R&D priorities, which we don't hear enough about, I think. They're really profoundly important and impactful, and I think this is going to be a great opportunity to go a little deeper on those. After we hear from Dr. Clancy and leave some time for questions and answers, we'll move to Emily Holubowich, who is the Vice President of Federal Advocacy with the American Heart Association. And I'm sure many of you know Emily. She is a budget and appropriations expert and kind of our go-to, never more important than this year with the plethora of budget and appropriations related activities that are ongoing. And so housekeeping wise, I think probably you all know, type your questions into the Q&A box. Right now you're all on mute as part of a Zoom webinar, but if you would type your questions into the Q&A box, as we go along, we'll definitely get to them when my colleague Terry Schwartzbeck joins us to do the Q&A portions of this event. So Dr. Clancy, with that, let me turn to you.
Well, thank you so much for the introduction. I've really been looking forward to this. I think that many of you are aware that VA has a research program, but I'm going to bet you don't know just how extensive it is and how much we've contributed to COVID and many other aspects of American medicine. Next slide. So what I want to just touch on quickly is the power of multi-site research, VA's research priorities, and frankly, what's been usually exciting to me this past year, and a year that's been scary and exhilarating and exhausting all at once, is that our system really stepped up to the challenge of being a learning healthcare system by leveraging all of our research assets for taking care of veterans. And just close with a few comments on vaccination and health equity, because I know many of you are hearing all about that. Next. So just by way of a brief background, we are the largest integrated healthcare system in the country. A state-of-the-art electronic health record, you might ask, why are we getting a new one? That would be a topic for another day. But the bottom line is we have had easy access to clinical electronic data for about 25 years. We have obviously geographic and demographic diversity, and very importantly, from the outset, embedded researchers who are also faculty members at the nation's top universities. And what we have and have been building is the ability to rapidly self-fund multi-site clinical studies to answer important and urgent clinical questions, which I think was quite an asset this past year. We really started this a couple of years ago to be a better partner with industry, but it turned out to be absolutely vital in our efforts around COVID. Next. So the power of this work obviously is very much about providing evidence rapidly about safety and effectiveness. And very importantly, veterans, especially those with conditions that are beyond routine, which is many of the veterans we serve, gain access to potentially life-saving or life-enhancing treatments more rapidly. We follow all of the common rule requirements, and indeed we register all of our clinical trials at clinicaltrials.gov. Next. So I did just have to show off. This came from when he was then vice president, but we were actually able to take the challenge of the cancer moonshot, working with the Cancer Institute and the Department of Defense to really make a big difference. And I'll tell you more about that in a moment, but I'm saving this slide forever. Next. So there are three overarching strategic priorities. One is to increase veterans' access to high quality clinical trials. Now, some of you may be thinking, duh. Let me tell you how this worked when I first came here 7 years ago. I would get calls from friends and people I'd worked with when I was at ARC saying, you know, we're starting up a study on Alzheimer's or something, and can veterans be in it? And the unofficial answer was more or less, well, of course, veterans are Americans. And if you find them and ask them to be in the trial and they want to, that's good with us. We're not stopping you. Now we've been far, far more strategic about it. So that's what I think is the real big difference. Increasing the real world impact of VA research. Arguably, we probably do more clinical trials than any health system with an embedded research partner. And very importantly, although this remains a tiny bit future tense because of security concerns and so forth, we want to put VA data to work for veterans and make it more accessible to external researchers. Next. So again, the access to clinical trials we think is really, really important. I wanted to mention Navigate to you. I went to quite a big celebration at the Murtha Center about 4 years ago. I mean, this was the place to be seen. The speaker was there, and I learned what a mentor Jack Murtha had been to her, and many, many dignitaries. And on the way back, I asked my colleague in charge of specialty care, so what is our connection here? And he told me all about this activity called Navigate, where actually we work collaboratively with the Cancer Institute to enroll our veterans in their clinical trials that they wouldn't have had access to, that we weren't conducting anything like it at VA, and are really optimistic that we may do more of that kind of thing in the future. Next. Real world impact. I want to give you a very clear example. Again, thinking about the cancer moonshot, shortly after the moonshot got established, we partnered with the Prostate Cancer Foundation, and they were quite purposeful in selecting VA as a partner to focus on cutting edge treatments for prostate cancer. And our motto over all of this is no veteran left behind. Just because you live far from one of our clinical centers does not mean you can't have access to this treatment at all. And the Cancer Foundation was very interested precisely because of the population diversity. That has grown from there, but it's not just about research. We're actually creating what we're calling a system of excellence within our healthcare system, so that we have researchers working alongside clinicians, so that as we are learning about successes, we can literally put that to work for veterans with very similar challenges pretty rapidly. Next. Now, COVID, of course, was the real test. Can we really be a learning healthcare system? One of the things we learned and have known, but we really got to test it empirically. So these are just even preliminary results. Many veterans view participating in research as part of their continued service, giving back, and they're quite purposeful about this. So in order to test this thesis, and we were looking for volunteers for vaccine trials and therapeutic trials, we went out to a smallish number. This wasn't even the whole health system number of facilities. And we used the infrastructure we had developed for the Million Veteran Program to ask, would you be willing to be contacted about a trial? I mean, within a matter of days, literally probably a couple of weeks, we had 58,000 veterans who raised their hand and said, call me, which I thought was just remarkable. And about a quarter of those were from underrepresented minorities. So you can see the power of this very large system. Next. So when the pandemic first hit, I mean, when we first grasped that it was actually on our shores and not just something hugely fascinating to read about in another part of the world, our Chief Research and Development Officer made very, very clear that the top priority was to keep research staff and participants safe, right? You all remember when we went into total lockdown in mid-March of 2020. And to support the clinical mission, we wanted to provide access to investigational therapies available only through research. And we focused quite purposefully on evaluating scientific literature and real world evidence to support operational decision-making right now. Remember, at the outset, we knew nothing. There's still a whole lot we have to learn. But we actually coordinated this with the World Health Organization so that we weren't making redundant efforts. If they were covering a topic, we said, great, we're going to go over here then. And we wanted to contribute to national research to combat the pandemic. Next. So these are just some examples. We are partnering with the Department of Defense on an observational natural history study coordinated by our cooperative studies program. We've been working closely with what I finally think of as Tony's Institute, Allergy and Infectious Diseases, testing different therapeutics. And we've actually created a wide-reaching VA cures master protocol to enable a series of clinical trials across VA. And one of the first tests of that was examining the effects of convalescent plasma. Next. So we've also been working with Operation Warp Speed. Now, if there's any regret I have about this, it isn't working with Operation Warp Speed. It's that they really actually didn't get what an asset VA was to their enterprise. But we were part of several of the vaccine trials and several of the therapeutics trials as well. Next. So I just wanted to brag for a moment about big data and informatics. Almost by definition, the size of our system, we have 6.5 million active users of our system, about 9.2 million veterans are enrolled. So we have already created a high quality database of people who've tested positive for COVID. And this is done in very close collaboration with our clinical operations folks. You all may have seen newspaper clippings about a study published in Nature last week that comes from a team in St. Louis, where they were looking at the continued prolonged effects or slow or long haul COVID in people who were not hospitalized. Kind of scary, right? We've been worried about deferred care and are most appreciative of support from the administration for those additional resources needed. But now this study is telling us there's a whole other layer to this that we actually hadn't been aware of. And I think that together across the research enterprise, we're all going to be learning a whole lot about this. But at this moment in time, I do believe this is the largest study of its kind. And I would have to tell you that many, many people have used our database of patients hospitalized, tested for COVID, and so forth, to publish many, many different studies. And of course, the first one out of the gate was hydroxychloroquine. That I will need to tell you much more about in real life when we can do it over an adult beverage. We also have learned this past year how we can be more effective partnering with our operational teams. And of course, I think many of you are aware of our Million Veteran Program. We have about 880,000 veterans enrolled. So the power here is that we have a database like no one else has, which is people's genomic data and their clinical electronic data for all the healthcare that they received. So I think that we will be gaining a lot of insights about COVID, its impacts in relationship to an individual's demographic, genetic profile. Next. So wanted to just close on the topic of vaccine hesitancy. We could see very early in the pandemic that veterans of color were far more likely to be tested, to test positive for COVID. And early on, it appeared that there were no differences in outcomes. We're seeing a slight difference in mortality rates now, to my best read, but far, far less substantial than what we have been reading about in other studies. But we recognize that vaccines is a tough topic for many, many people. So our Office of Health Equity leaned forward on this in a very, very big way, having a lot of listening sessions with these veterans, finding out what they knew, what they needed to know, and what they would trust. Many said they would trust their doc. So that's a very positive sign. The sessions included opportunities to address specific concerns, the infamous Tuskegee study, and so forth, and to attempt to reassure by just describing what happened, the current data on vaccine effectiveness. I mean, we've never done anything at this kind of warp speed in our country in relationship to vaccines. We're usually talking about years, right? And this has just been mind-bending and really exciting, but I think also leaves some people worried that maybe we move too quickly. And they also gave us some very good feedback on how we could get that information to them. Technology I use now. I don't actually want to learn 10 new programs. I want to use something that's really easy for me now. And we learned that linking that directly to a specific action, for example, scheduling an appointment for a vaccine, made it that much easier. Next. And one thing I have relearned is that we started planning for vaccine rollout in August of 2020. I mean, if you think about this, we didn't really know what the time frame was going to be. I don't think states started hustling on this till November, December, but we were rolled out because this is something the system does very, very well. As I mentioned, we developed the targeted messaging, and we have been ahead of many systems in terms of our footprint in telehealth. So we have many, many different kinds of channels. One of our biggest challenges, of course, is that many of our veterans live in rural areas where you can't count on broadband everywhere. And we were able to leverage our electronic health record to identify eligible veterans, contact them, schedule appointments, and so forth. Next. So this just further describes what we did by way of outreach in terms of having spokespeople from VA reach out to veterans and make very, very easy to understand messages. I just have to say I was very, very proud of this system recently when the Janssen vaccine was paused. We were actually able to figure out pretty quickly for us, that was about 5,200 women who'd received Johnson & Johnson shot in that age group. And we were able to reach directly about 95% of them, which is awesome when you think about it. And that doesn't mean we got them all on the first try, but nonetheless, we were able to reach them. Next. So I'm going to pause here. I've probably spoken too rapidly, but it has been, as I said, an exhilarating, scary, and exciting year as we have learned as a health system how to respond to this pandemic and how to leverage that research asset to help our colleagues in the field taking care of veterans right now. And thank you again so much for this opportunity, Ellie.
Dr. Clancy, that was just terrific. I have approximately 3 million questions, and I'm going to limit them to 2 for now and then turn to Terry. Are you that incredible, well, actually several incredible databases you have, the natural history study, the COVID tracking, COVID-19 infections, hospitalizations, and you mentioned long COVID. Are you working yet with Dr. Koroshetz on the long COVID work that NIH is doing?
We're certainly following very, very closely, and some of his most dedicated fans are some of my colleagues. We certainly will be. This team in St. Louis, I don't know that they have been reaching them. And I think that our efforts will be highly complementary, but I don't regard this as a race. I regard it as a, desperate need for all of us to.
That's it. It just seems like you have captured so much data.
Yeah, and what we also have is we know the specific details about when people seek care.
Wow.
Good
point.
The team in St. Louis was actually able to isolate those people who tested positive but were not hospitalized.
Wow.
Which I think is one important subgroup, because on some level, it's very easy to imagine that the people at highest risk of long COVID are those who were hospitalized and had a rocky course. That may not be the case.
Right.
But we're definitely looking forward to partnering with anyone working on this, because I think this is a story that's going to unfold over a number of years.
It's scary, the possibility of another set of chronic diseases or a single chronic disease. Another question, clinical trials diversity. Has the VA, has that been a challenge for you, or are you seeing that the methods you use just capture a diversity of participants?
In some cases, we have reached out quite purposefully, but it has not been a big problem for us. And in a funny way, the listening sessions and anticipating and leaning forward on vaccine hesitancy sort of reinforced what we knew, right?
Yeah.
Now, it's a different message to say, gosh, we're doing a study and we would like you to be part of this. But then it is to say, we've got a treatment and we would like you to give it serious consideration, and to know exactly how easy it is to get it from us and so forth. But again, a lot of this comes down to trusted sources of information.
Yeah.
So I'm really, really proud that so many of our veterans report trusting their doc. At the same time, I'm a little tiny bit worried by that because I think for younger veterans and younger people in general, right, this connection to an individual is a little less meaningful than for some of us who are more mature, shall we say. Uh, Probably a stages of life kind of thing, right?
Yeah.
You've got a cadre of young veterans and young people generally who are they're digital natives, right? We've all learned,
Right.
we keep learning new tricks, especially this year, but they really, really know what they're doing. And many have lives where convenience and time is just a huge asset. So if I can see the same person every time and I really like that person, great.
Yeah.
But if you can guarantee me it's going to be 4 o'clock because that's when I've got time, that's great too.
That's one thing I noticed really quick before I turn to Terry is that, and I've heard several reports on this, but I don't know if it's just anecdotal, but that convenience is overwhelmingly important. That if
Yeah.
you happen to be in the CVS when there's an extra dose,
Yeah.
you're like, okay, it's very interesting. I imagine the VA is good for that because you have convenience is baked in for
Yeah.
your veterans. So Terry, join us. Do you have questions from the audience?
I sure do. And just a reminder to folks, you can type those into the Q&A box. Dr. Clancy, earlier you mentioned a little bit about long COVID. We have a question wondering if there's anything specific around mental health research planned for ongoing and long COVID patients.
We are definitely seeing some cognitive impacts and impacts on the brain. And, this study that was published in Nature was quite literally and highly appropriately described as a landscape view. But I think that we will be learning much, much more about that. Interestingly, what we've seen, and I think many of you have probably seen in newspapers, is suicide prevention is one of our highest clinical priorities. And we have not seen an uptick in suicides that we can see, nor has the country. What there has been is an uptick in opioid overdose.
Okay.
And I have not heard how VA's numbers stack up against that. I find it a little credulous to think that we would have avoided that altogether. But I think many, many people are worried about the impacts of isolation, and we treat many, many people with mental health disorders. So we're getting ready. We
Yeah.
are ready, but it is something we worry about a lot.
Yeah.
Sure thing. Thanks. And then another question. You mentioned your electronic health record system. Is there something new and cutting edge? Can you tell us a little bit more about that?
So several years ago, our then Secretary, Dr. David Shulkin, thought that the best way for us to go, creating a lifetime record for veterans, was to join the Department of Defense in implementing the Cerner electronic health record. So we actually believe that when we get this right, which is not right this second, we will be able to move much of the rest of the country in terms of how do we use the same platform to provide great clinical care,
Wow.
to support all the other healthcare needs, and to conduct research.
Wow.
I do want to be clear that we have not done that yet. In fact, we just had one deployment, which obviously was complicated by the pandemic, and are doing a review to make sure that we can be positioned as strongly as possible. But this has been the aspiration and research for a really, really long time, right? That you could accelerate access to clinical trials, right? I mean, now we've got this idea that the light bulb has to go on over a doctor's head, right?
Right.
Oh, this patient might want to be in a trial. If Disney were designing this, that information would be beamed right to you. And technically, that's not hard, right?
Right.
It's more a matter of figuring out how to do that. So I'm looking forward to getting this done in the future because I've been fantasizing about it for a long time.
It's amazing. It's an amazing aspiration.
Yeah.
Great. There's another question just came in. You mentioned that the VA has rapidly self-funded some of these clinical trials and research protocols. What kinds of impacts have these unexpected investments had on the research program in terms of cost? And how do you see this impacting funding going forward for non-COVID research?
Well, I'm so glad that you asked this question, obviously, or maybe not so obviously. And I think this is as yet an untold story across the country, right? Some kinds of research had to pause because if you had to be there, that was going to be a problem. So like many other organizations, we are, trying to figure out how much of this can you do virtually and so forth. And I think that's going to be a very exciting development moving forward. When I say self-funded, VA is an intramural research program. Okay, so we fund people who work for VA. Sometimes people can get appointments for which they're not paid, but then they would have access to our data. This is not the slickest mechanism going. We would actually like to make the data a public use asset, and that's the piece that we're working on. But all of our research, by that definition, is self-funded.
Terry, if you don't mind, that was a question that I had. So right now, are there any VA databases that are public use that any researcher has access to, or are they all locked?
Not yet.
Not yet.
No, but we're in active conversations with the Chicago Data Commons, the one that NIH uses and so forth, to make a lot of this information available.
That's
and
terrific.
We've also been working with other federal partners and the high-speed computing group at Oak Ridge, which is part of the Department of Energy. We were doing that before for genomic work, but this past year we actually put all the mechanics in place for developing insights about COVID as well. So watch this space. And of course, we're hatching other ideas.
Right. It's complicated, I know, to de-identify, all of that information and everything. So I'm sorry, Terry, I jumped in.
No, that's great. Thank you. One other question. You mentioned earlier some of the many pivoted services you've rolled out during the pandemic, including telehealth, more apps, more mental health support, things like better appointment scheduling. How do you see these virtual services progressing as we hopefully start to see some of these pandemic restrictions subsiding? So
you've just hit on my all-time favorite question. I am more than mildly obsessed with the question of what does healthcare look like post-pandemic? What's the new normal? It is almost impossible for me to believe. I mean, I think I read somewhere that 3 in 10 adults, or 1 in 3, roughly the same thing, have had at least one telehealth visit, during this time. That works well. And sooner or later, a lot of people are going to be saying, do I need to go have a parking challenge if we can do this virtually? No, I don't. And well, it all comes down to time management, right?
Time management.
Make sure that the other members of your team, especially if they're virtual, I mean, how are we all on the same page in making this work? That's not a technical problem. And, frankly, being connected to a number of folks who absolutely loved it, I had to teach them about it at first. I don't think they want to go back. Now, obviously, reimbursement issues. VA has actually been at this a little bit in a boutique fashion since about 2006. This year, we really had to blast it forward because, we were trying to minimize risk to veterans and frankly, to all of our employees as well.
Wow. It's so exciting.
It is.
Great. Well, I'll hand it back to you, Ellie.
Great. Well, it looks like we're just about at the end of our time, unfortunately. I think that we could keep you here, Dr. Clancy, for 3 or 4 hours easily. I'd love to talk to you about health services research, specifically the crossover between VA and ARC. But instead, I think we better turn to Emily, who's been waiting patiently. And thank you. And hopefully you'll come back and visit with us again soon so we can get to more of these questions.
That would be fantastic.
Okay.
Bye-bye.
Well, thank you so much, Dr. Clancy. And Emily, hi.
Hi.
We are thrilled to have you here. And as you know, what we're hoping is that you will demystify to the extent possible, and knowing that things change every second, where various agenda items are housed in the budget process, appropriations versus where things are between budget committee, appropriations, 302A, skinny budget, overall budget, something like that.
Oh my gosh.
Easy.
Well, Ellie, it is so great to be with you and the team from Research America. Whenever you ask me to do anything, I gladly do it because I think the world of all of you and you're great friends. So thank you so much. And it's so especially nice to share today's time with Dr. Carolyn Clancy, who I worked with so closely for many years, advocating for health services research, which I still do, and the Agency for Healthcare Research and Quality. She's such an incredible leader, an incredible woman. I admire her so much. So this is a special treat for me. So I'm going to call on you, Ellie, to keep me on track with time, because I actually do a college lecture about the budget and appropriations process and can go at a minimum of 2 hours. So I'm going to do my best. And so I thought what might be helpful is to start just at a very high level of kind of like where we should be and how the process should work, and then talk about where we are right now in this moment and where I think we could be heading. And I will note, I do not make predictions anymore, but I do have some considerations that are top of mind for me that I want to throw out for people that I think could influence either the success or failure of the appropriations process this year.
Perfect.
And so I've been doing appropriations for 20 years. I have learned to expect the unexpected, and no 1 year is like the other. And every time you think it can't get worse, it does. So with that, I'll start. And before I do, although I have to give a shout out to my colleague, John Lochner, who leads our appropriations work for the American Heart Association for research and public health. So hi, John, thanks for tuning in. And thanks for all the great stuff you do. So with that, how it should work, I did put a link in the chat to a very helpful timeline that I actually developed when I was the executive director of the Coalition for Health Funding. It's still available on their website, and they are a great resource for everything health and appropriations and budget. So publichealthfunding.org, and you'll see the link to the timeline in the chat. But essentially, how it should work. And this is the process for the modern budget and appropriations process that was really established in the Congressional Budget and Impoundment Control Act of 1974. It's actually the last piece of legislation that President Nixon signed before he resigned, fun fact. And it really set out the process that we know of today and how the budget should be developed. And essentially, it really kicks off in earnest, typically, or should, with a date actually codified in law, which is that the president shall present his or her budget request to Congress on the first Monday of February. From there, some other key dates to note, it is up to then, of course, under Article 1 of the Constitution for Congress to take into consideration the president's budget request, but really for them to develop appropriations legislation. And part of that is deciding how much money you're going to have available to spend across the federal government. And that is set in the budget resolution. And typically the budget resolution should be enacted by Congress. It is not signed by the president by April 15th. If it is not, they typically miss that deadline. This is going to be a theme. Congress may essentially deem a level of overall spending. That's what we call the 302A. It actually refers back to Section 302A of the Budget and Impoundment Control Act. And that's the overall amount of money that Congress is going to work with in making spending decisions over the course of the year. They then work beginning with hearings and markups kind of over the course of the spring, all working up toward what would hopefully be regular order, which is moving the 12 appropriations bills through each chamber and then conference through each chamber again and signed into law before the fiscal year ends on September 30th. So the fiscal year, this is a condensed process, so probably won't surprise you that they frequently miss these deadlines and don't meet their timeline and don't move in regular order. In fact, since I think 1957, they've only moved through true regular order appropriations bills in 3 fiscal years. So they actually, irregular order is more regular than regular order. So I would just note that for those of you who get frustrated and really like plans and deadlines, just know that this is all more like guidelines of, how we would like the process to work. It rarely works that way. And so where are we now? So if we look at that timeline and now we look at where we are now, you're going to see a theme in my discussion, and that is we're already behind, which is not boding well for certainly regular order, and really just makes me nervous generally. I'm always nervous about the appropriations process, but I think we are real behind. And I will say it is not atypical to have a delay in the president's budget request in a presidential transition. In fact, that's pretty normal and it's expected. I think what's a little unusual now is how delayed we are. I can't recall, I've been doing this for 20 years. I can't recall a time where the budget has been this late. And that is, we're still waiting and it's still under development. And I think there are a lot of, you could explain away a lot of why that is. It was not a smooth transition. We still don't have an OBA permanent director confirmed. There are a lot of other things happening, including American Families Plan, American Jobs Plan, lots of plans, American Rescue Plan Acts in the first 100 days. So there's just been a lot of things happening that I think is slowing down the budget release. But we're right now hearing no earlier than Memorial Day for the full president's budget request, which means really things are kind of in a holding pattern on the Hill. Certainly appropriators are beginning their work and they're beginning to move forward. And I should note that the president has put forward what we affectionately call in Washington a skinny budget. That is essentially a high-level overview of an executive summary, if you will, of like the major priorities for the administration and the general approach that they're taking to the budget. And there are some bright spots there. I think what's really exciting for advocates for research funding and public health is there are significant investments and commitments that the president is hoping to make. The first, overall is a 16% increase in non-defense discretionary spending, or NDD. This is the domestic spending that people think about. Everything the government does, it's essentially not the Pentagon and not entitlements. And really the kind of the core functions of government that people think about. And so I know Research America was working real hard with the Coalition for Health Funding and NDD United and others to stop sequestration and really end that era of austerity. And so it's after years of basically stagnant funding, this is a really exciting development to see this commitment to really bolstering domestic spending. In particular, $51 billion proposed for the National Institutes of Health. This, in the fine print includes $6.5 billion for a new Advanced Research Projects Agency for Health, or ARPA-H. The idea, building off of DARPA or ARPA-E in the energy space is, this would fund high risk, high reward research across the public and private sector, really stimulate development in new technologies and treatments. How this is going to play on the Hill, I think really remains to be seen, but this is certainly something to watch. Nonetheless, a serious commitment on the part of the administration to research at NIH, and I'd say across science. This administration really leading with science, be it, NSF, ARC, otherwise, really some positive developments there. We see a $1.6 billion increase proposed for the Centers for Disease Control and Prevention. This would be the largest discretionary budget increase for CDC in 20 years. Within that, there's a proposal to significantly expand the CDC's new program around social determinants of health. So again, another key focus of this administration, they're leading with science, but they are leading toward equity. I think equity is a huge priority for this administration that's already borne out. And we're seeing that reflected throughout the president's budget, including in the proposal for CDC. So that's kind of high level, the highlights from the skinny budget. Because we don't have a president's budget, we also now don't yet have a budget resolution. So we've already missed that deadline for Congress to adopt a joint budget resolution to set the overall 302A discretionary spending levels. And they're kind of waiting. I mean, they, obviously, when Congress is going to do their thing, this is their constitutional authority. But when you have a House and Senate of the same party of the White House, they want to give some deference to the White House and see what they have in mind. And so we understand from Chairman Yarmouth in the House Budget Committee that he's kind of holding off on a budget resolution until he sees what's in the president's budget. So we're looking at least June for a budget resolution. Now, there's an interesting caveat in the Congressional Budget and Empowerment Control Act, and that is if Congress is not timely and they do not adopt a budget resolution by April 15th, appropriators may deem the level. So they basically set the overall spending level for themselves. This allows them to kick off the process and begin work on appropriations bills. So we could still see that happen. And there is some talk of that. And that would allow them to begin, making what we call the 302B allocations. So think of the 302A as the size of the pie. And then the 302Bs are the slices of the pie that they divvy up to each of the appropriation subcommittees. And that's where they begin then to say, okay, how much of that 302B goes to NIH and how much to CDC and how much to ARC, how much to the Department of Education. So all the things within the labor HHS education appropriations bill. So we're behind. That's sort of the bottom line. And I think it's very, interesting you held this today, Ellie, because today is the deadline for appropriations requests in the House, which is kind of, I think, like a soft deadline. Yes. I mean, get your requests in, but we got a ways to go before we start writing bills is kind of the bottom line. And so I promised I would not make predictions. It's just way too hard, but there are some things that are top of mind to me, and I categorize them as the good, the bad, the ugly of how this could play out over the course of this year. In the good category, I will put earmarks. So for the first time in a decade, we have a return to earmarks or community project funding requests. The idea here being, I think, and you can debate that. There's a lot of robust debate about the value of earmarks and are they incentives or not. But I think for a lot of lawmakers who've been around a long time, who have seen the process function at least better than it has, they really look at earmarks as a key tool to getting bills passed and getting them passed in a bipartisan way. Because if you are not on the Appropriations Committee, you don't necessarily have skin in the game. You don't see the value of these spending bills and their impact on your community. But when you can go back as a lawmaker and say, look, I got $1 million for this new community center in our community, or I got this many $1 million to repair those potholes or build that bridge or whatever, that is meaningful for members of Congress, and it makes them more inclined to support appropriations legislation. So interestingly, not too in the weeds, Senate Republicans have maintained their ban on earmarks, although they're not like enforcing it. So it's like a ban, but not really a ban. And if you're a Republican and you are so inclined, you can still request earmarks. Chairman Leahy of the Senate Appropriations Committee is developing guidance and they're moving full steam ahead. So you're not going to be like punished if you seek earmarks, but there will be a handful of lawmakers in the House and in the Senate who just won't do earmarks on principle. It's just not their thing. But just so you know, like earmarks are still a thing in the Senate and they are moving forward. And I do think that this helps get to bipartisan bills. And I think it makes it more likely you can get to 60 votes on these bills. So this is overall a good thing. Some of the bad, and as much as lawmakers like to say they can walk and chew gum at the same time, they're really bad at it. And we're seeing that now. I mean, the oxygen in the room for the foreseeable future will be on the American Jobs Plan and the American Families Plan. And are we doing this bipartisan or are we not? Or maybe there are parts that are bipartisan that we move through regular order, but there are other parts we're going to do through reconciliation. And I can do a whole deep dive on reconciliation. But all of this to say is this eats up valuable time and energy. It also eats up political capital. And so what I mean by that is You may have noticed the American Rescue Plan is the only of the 6 COVID packages that did not receive any bipartisanship at all, no Republican votes. There is, if you're paying attention, you saw a lot of complaints about Democrats cramming this through, using reconciliation, not working in a bipartisan way, not listening to Republicans. Democrats, of course, will say, well, we know you're not serious, so we're just plowing ahead without you. But that left a mark, I think. And I worry a little bit that pressing ahead on reconciliation for more trillion-dollar spending is going to make Republicans more entrenched. And do they take out their frustration on the appropriations process? And do they say, we're just not going to vote for these bills because we don't want to vote for another $1 trillion in spending? This is a very real thing. So how the debate plays out on infrastructure and these bills, I think is going to really tell us a lot about our chances for appropriations. And I'll just say I'm nervous. The ugly is, I will say, if we look to history, I'm going to go back a decade, it feels a lot like 2009 to me. And you'll recall in 2009, we had a recession, we had significant spending, less than $1 trillion, not even close to where we are now with 6 COVID bills. You may have noticed the deficit hawks are rising like phoenixes from the ashes. It just a lot of concern about debt and deficit. We're seeing that in polling of Americans. Like, is it too much spending? How does all this spending impact inflation? There are the bigger fiscal policy questions that I wonder about the impact on the election in the midterms, which frankly, not looking good for House Democrats based on census data alone. And do we end up in a scenario where it's basically 2010 again? And so we have Republicans shellacking in the House. We can't get appropriations bills done next year. You'll recall in 2009, we punted, and that's the last time we had earmarks. And they almost got bills done in the lame duck. And then Brian Williams talked about how bad earmarks are, and the whole thing fell apart. And they punted into early 2010. And that's when we had HR1 proposing a 20% cut to domestic spending. And then the debt ceiling, and we're not going to increase the debt ceiling unless we cut spending. And that led to the first $1 trillion in cuts in discretionary spending. And then we had the Budget Control Act and austere caps for 10 years and sequestration, and on and on and on. So it feels like history is about to repeat itself. And so again, I'm not making predictions, but I've seen this movie before. I think I know how it ends. And so for me, the urgency around appropriations this year, and I think this is key for all advocates, is I feel like this is it. This is the year. I'm not convinced you get appropriations bills next year. There's too much on the line with the election. I don't know the outcome of the election. I can my spidey sense is going off. I feel like I know where things are headed. And that does not look good for appropriations going forward or increases in domestic spending. So I'll leave that there. And I would note, this is the first year that we don't have budget caps. We were successful in sort of staving off sequestration, which would have been even more austerity. But those budget caps for the last 10 years were pretty austere. And, we did not see significant growth in a lot of programs. NIH fared fairly well, but CDC, many of those programs were largely flat funded. ARC lost money. It was just, we won and that we stopped sequestration for the most part, but it was still pretty austere. So, are we staring down the barrel of Budget Control Act 2.0? These are the things that keep me up at night. So that's not a very cheery thing to end on. So all that to say, things are not normal. It is normal to feel confused. And we just gotta kind of ride it out and sort of be vigilant in our advocacy, because I do think this is our best shot in this year to get whatever we can for these programs before we're locked in either through a year-long continuing resolution in next year, or hopefully not, future budget cuts. So.
Well, Emily, let me start by saying thank you, because not only was that really informative and pithy and in English language, I mean, I understood what you were saying, but you were so candid with us and truly appreciate it.
Yes,
I have a question that's a little bit, I think, one of the things that has been back and forth in my head. So the need that is still compelling, I think, to our community to recover from COVID, for the system itself, the research system to recover from COVID, and the fact that right now dollars from the current year are being diverted into backstopping for COVID damage. And in one of these reconciliation bills, the jobs bill, there is about 30 billion, I think, that is not specified for R&D. It's for R&D across the ecosystem with some focus on rural.
Yep.
But it's a potential pot of money for research relief, I think.
Yeah.
What's your thinking on, and the term research relief is a tricky one, but supplemental funding for this issue?
That's a great question, Ellie. And I know, there's legislation out there, the RISE Act, I think, $26 billion to sort of help bolster the research enterprise. And I would also just note, it's not the research itself, but also researchers. I think that's really important as
Yes.
you think about, in particular, the diversity of the research workforce.
Yes.
Where we know, I think 9 million women are still unemployed because of the pandemic, leaving the workforce to take care of family. We've heard this anecdotally from the research, the American Heart Association funds, from our own researchers saying, everything from, my productivity's never been lower, like I can't publish like I used to, I'm considering leaving because I can't do this. Like it's just too much. So I think, in telling the story, that's important as well. And probably even more important, not just the effect on the research results, but research doesn't happen without people. And so making sure, and I know you all have done this and have been doing a great job of it, I could continue making that case that this is having an effect on the research workforce, and it's disproportionately affecting women, people of color, the very folks that, we in the community want to see succeeding in research, and we want more to help them. And we're being set back years. In terms of prospects, I think as we did with sequestration, which felt like a lost cause, I really do feel like what turned that around were the stories and the stories of impact. And without that consistent drumbeat about the impact and sharing those personal stories, I think it's a heavy lift. I feel good about the sort of baseline appropriations process.
Yeah.
But in terms of supplemental funding, there are so many needs, and I'm thinking of a lawmaker. Top of mind for me is going to be like that working mom waitress who has been out of work, like that's not white collar jobs. I mean, that's not where their heads are. That's not to say that this isn't important, but I think we need to connect the dots for folks that, the experiences that working class Americans are feeling are very similar to what we're feeling in the research community. And we have a very similar experience. And, these are people too, and they need help too. I think we as a community, we need to connect those dots. I don't think they're getting that. And how we do that is bringing forward the stories that I know Research America has been collecting.
And I think that goes to your point with appropriations, that since appropriations are across the board, agency-wide, it's harder to fight for them against a deficit argument than it is when it's a specific issue for a group of people are in trouble.
Right.
And so I know that there are a lot of questions for you, so I am going to zip it.
And I would say one thing on that, Ellie, and I think as a research community, we have to think about this too. I know I think about this in public health. There's a real danger. It's like, okay, great, we're doing increases, but where are the increases going? And everyone's excited. You know how Congress is.
Yep.
Oh, let's put all the money on opioids crisis, fund opioids.
Yep.
Oh, COVID, fund COVID. So, I think we could be seeing, not that COVID research isn't important, because it is, but not at the expense of other research, right? Like, we have to make that case that the continuum is important. All
That's
these
right.
research pots are important. Like,
Yes.
it's not,
Raise all boats.
we can't just be focused on COVID. Even though it is top of mind and it is very important and we need to be putting money there, but everything else needs funding too. Like, we just need to keep hammering that home. So we don't end up, cannibalizing ourselves in the community.
Absolutely. Terry, do you want to join us?
Yeah, sure. Thank you so much, Emily. That was fantastic.
Thanks,
I want to start by asking, let's get out the crystal ball tonight. As we know, President Biden is getting ready to address that joint session of Congress. What do you think we're going to hear? And in particular, what do you think we can expect to hear about his research funding priorities?
This is great. So I will first share, center stage for tonight is going to be the American Families Plan. Well, and I will say this, I think first, I've seen some reporting on this. I think we can expect, a victory lap of some sorts on the COVID response, vaccination rates, et cetera. And, the American Rescue Plan Act, the administration sees this as a win. So we're going to see them talking about that. And then that leads into, and here's why, we're proposing what we're proposing in the American Jobs Plan and the American Families Plan. So we'll see a lot of focus on that. I think we'll see a focus on equity. It'll be interesting. I don't know how much he'll go into the budget and his budget request. If I were to guess, I think it is probable that if he does talk about research, in R&D, it might be very high level, very general, or if he digs a little bit deeper, I would expect him to highlight the ARPA-H proposal and particularly cancer research, given his connection to the cancer moonshot, the death of his son Bo, that for me would be logical to see him highlight. But I think most of the time is going to be focused on the American Families Plan, which of course is, all those Democratic priorities, paid family medical leave, extending the child care tax credit, making the ACA premium subsidies permanent, all of those things that hit American pocketbooks, is what I would expect him to be laser focused on tonight. Again, I stopped making predictions after the 2016 election, so don't hold me to that. That would be my guess.
Well, that's why we said crystal ball, crystal balls have varying reliability.
I'm not putting money down. And I will put in the chat, there is a link to the high level summary of the American Families Plan that came out earlier, if people want to take a look. For us, the American Heart Association, there's a ton of stuff in there we love. Particularly around nutrition security, the ACA premium subsidies, lots of stuff to like for sure. But yeah, I don't know how much he'll delve into the skinny budget proposal, and if he does, I would expect it kind of toward the end. So you got to watch the whole thing if you want to see him talk about research. That would be.
Well, I think we hopefully have time for another question. Emily,
yeah,
before we lose you?
Sure. One more real quick, just any advice for the advocates who are out there listening, where should they be focusing their energy? What's something they can do to work on that research funding piece to make sure that their members of Congress are hearing them?
Well, I think participating and in whatever Research America tells you to do is a great start. I'm sure many of your folks are part of professional societies that are also advocating on this. So when you're getting those alerts to take action, do it. It really, really does matter. And it doesn't feel like one voice makes a difference, but the collective voice does. I've seen this happen time and time again. both in advancing good policy and preventing bad policy. So take action on those Research America alerts. And I would say, do so in a way that you do personalize it and you share that story. And I know for scientists, anecdotes are like the lowest level of evidence, the lowest standard of evidence, but for policymakers, it's the highest. I'm going to quote my good friend, colleague, Lisa Simpson, at least heard me say this before: data make you credible, stories make you memorable. Stories are the coin of the realm. If people were allowed in the gallery tonight, there would be people in the gallery with First Lady Jill Biden. And I know President Biden would be pointing to them and sharing their story as why he's proposing what he's proposing. He'll probably do that anyway, but if you have any doubt that your personal story matters, you should let that go, because it really, really does. And it makes or breaks whether or not we have progress on policy.
Beautiful answer. And I wish we could keep you and Carolyn, as you know, forever. I want to just also add to what Emily said, is that if you have ideas, if there are ways you want to partner with Research America on op-eds, on LTAs, on brainstorming, messaging, talking through your story, email me, we'll get it done together. So, and the team with you. And Emily, you're the best.
Thank you, Ellie.
Thank you.
Love you guys.
I just want to leave you all with join our next one. Our next Alliance meeting is with Dr. Sharpless from the National Cancer Institute. We anticipate that he'll be discussing priorities for the Institute and also touching on ARPA-H and other really in the moment issues. So join us, and thank you for your membership. Contact me again also if you're not an Alliance member and your organization is interested, and I'll hook you up with our membership team. So, also join us for Jennifer Kama. She's also going to be joining an Alliance member meeting to talk about approach and priorities of her boss. So with that, I'll say bye and thanks for joining us.